Thanks, Jason. So like Jason mentioned, I'm Kelsey Digout, and I am the co-chair of our antimicrobial stewardship committee based out of the Yorkton Hospital or the Yorkton Regional Health Center. But we also cover an area of Southeast 3 to 5, which is Kenora, Kamsack, Priestville, Esterhazy, Melville, and a couple other little communities in that area. So there are other smaller hospitals as well that our stewardship initiatives try and reach out to also, which I will discuss about, which I will talk in a little bit. Oh, why aren't you going to the next slide? Okay, so just a reminder of our SHA vision, mission, values, and philosophies of care, that our vision is for healthy people of healthy Saskatchewan, and that our mission is that we care, we work together to improve health and well-being every day for everyone. And I think that antimicrobial stewardship fits in and aligns with this perfectly, that we are looking at ensuring antimicrobials will continue to work for a long period of time to continue to support and keep people healthy within Saskatchewan. I also want to acknowledge that I am speaking to you today from Treaty 4 here in Yorkton, and that I want to acknowledge that we are gathering on Treaties 2, 5, 6, 8, and 10 of the Cree, Dene, Assiniboine, Nakota, and Saulteaux territories, and the homeland of the Dakota, Lakota, and Métis. We recognize this history is important to our future and our efforts to close the gap in health outcomes between Indigenous and non-Indigenous peoples by knowing what the land and the traditional people of the land offer us. So, our Yorkton Antimicrobial Stewardship Committee. It has been around since 2013. It was first developed by two pharmacists and a physician who saw a gap in stewardship efforts and decided to get the ball rolling and develop this committee. So I will just point out that, I'm sorry, this is very hard to read and you probably can't read it, but it is the terms of reference for our committee. And to note that prior to being an SHA, and when our P&T committee, local P&T, so pharmacy and therapeutic committees, were still in effect, our antimicrobial stewardship committee fell under that umbrella. But then with the dissolution of the P&T committees, we haven't actually found a place where we fit in yet and who we report to. So when I do this presentation, I'm going to divide it into kind of two sections, what we did before and what we're currently doing now. So unfortunately, this terms of reference is outdated and we haven't been able to adjust it because we just haven't found a structure of where we fit in yet. But we do follow most of this stuff still. So for example, we do meet every 2 months as a committee. This sometimes will it ebbs and flows a little bit depending on vacation and if there's any leaves, but we do try and meet every 2 months. And our committee membership also changes a lot based on who's in what position and if there's any lines empty. So currently, we don't actually have anyone who is from our local lab department, because all of our microbiology samples now go to Regina. We do very little microprocessing here, so we don't have anyone local, but we do have a microbiologist from Regina who is ad hoc on the committee that we can refer to and get support from if needed. We have an ER physician that sits on as ad hoc that we can send information to, and then she reports back information to us as well as needed. We don't have a clinical educator right now because they have lines empty and aren't able to join us, but I still connect with them often regarding antimicrobial stewardship efforts. We do have a clinical coordinator from our surgical and OR departments that are on. We have a manager from long-term care in Yorkton who sits on the committee, and then we are also able to reach out to our other rural sites in, say, Kenora and Kamsack and Melville and Esterhazy through the hospital pharmacist there, as well as a couple facility managers as well. So that's kind of where we're at right now in terms of membership of our stewardship committee. And then I'll talk about what some of the things we have done. But when when the two pharmacists and the physician developed this committee back in 2013, they took information from the IDSA and AMMI Canada and the UHN out of Toronto and a whole bunch of different references on how to create an antimicrobial stewardship committee, since we still had our separate regions. But now there is this fantastic toolkit that Jason and Kristen and Mel and the team developed through the through the SHA antimicrobial stewardship team. On the SHA website, you can go to their antimicrobial stewardship tab, and there are references right there for you on how to build and how to sustain and how to get your antimicrobial stewardship committee going. And it's very simple. Your terms of reference is fully laid out for you. You just have to go and type in your facility name into the boxes that are designated and type in a few other key pieces of information. But it all is roadmapped there for you in this great toolkit of how to develop your own committee. So highly recommend going to that page or connecting with us if you want any support at all. And then the other thing to note is I'm not an expert. No one on our antimicrobial stewardship committee is an expert. But I think that's okay. And the reason it's okay is that we're advocating for our patients and we're passionate about antibiotics, and we want to make sure that they continue to work, and we want to make sure that they're being used appropriately and when necessary. And as much as I'm not an expert, I have experts to reach out to, and they help guide us and take us down whatever path we need to go to make sure that our antimicrobial stewardship efforts are being as successful as possible. So in Southeast 3 to 5, here for antimicrobial stewardship, what do? So I do want to talk about prior to dissolving our local P&T committee first, because that's where a lot of our policies came into effect. So I'm just going to jump to there now. So some of the policies that we created through our P&T committee this would be one, for example. We created an IV to PO policy for the pharmacist to be able to convert IV antibiotics to oral antibiotics without a physician approval or signing off on them if a patient met certain criteria. So this is actually a 3-page policy, and on the left here, I just took a snippet of the second page, and it does have there which antimicrobials can be converted from IV to oral. And then part 2 down on the bottom has the inclusion criteria and what has to be met in order for the pharmacist to be able to convert that IV antibiotic to oral. So you can see, I'm not going to read off the antimicrobials, but for the inclusion criteria, they have to have been on antibiotics for 48 hours. They have to be clinically improving and afebrile for 48 hours. They have to be tolerating their other oral medications or tolerating oral feeding, and there can't be any concerns with GI absorption. So this 3-page document was kind of cumbersome, and it was a lot of pages to put in the patient chart every time we wanted to do it, and it was a lot to handwrite out as an order. So about 5 years ago, the pharmacy team actually developed a sticker, which is there on the right. So it's a sticker that we just print off onto a sticker, and we tick off if the patient meets all 4 boxes. We simply tick them off. We slap that sticker on the physician order section of the chart, and we would write beneath it, change moxifloxacin to 400 milligrams PO daily for the remainder of treatment. And that's per pharmacy to convert based on this policy. So that is one of the things that we do on a fairly regular basis, and we continue to do. Other policies we have in effect, we do have a linezolid and fosfomycin restriction policy. These were developed quite long ago, back in 2014, but we still hold to them. The reason being is that their linezolid, obviously, we're wanting to reserve for resistant and severe infections. So that's basically what the restriction says. And now with the First Line app, and it mostly indicating if something is restricted or not, linezolid is one of those agents that is restricted. So now when we're rounding with the physicians, if linezolid is brought up, we 9 times out of 10, maybe 10 times out of 10, we're saying, please connect with the ID team to get some of their input and approval of using this agent. So that's for the linezolid. And then the fosfomycin, when it was developed, it was beginning to be seen as an antibiotic that it's kind of like Zithromax, right? It's easy to use. Zithromax only 3 days. This is just a one-time use. So we were kind of throwing it off to people unnecessarily. So a restriction policy did come into effect that said the patient actually had to have a UTI. They had to be symptomatic for a UTI. And then that urine CNS had to show that it was an ESBL producing organism that would be only sensitive to fosfomycin, that we can't just be throwing out fosfomycin to everyone just because it was easy to administer a one-time dose. So those are 2 of the restriction policies. The other one that we have is the meropenem dosing interchange. And I'm sorry, I did not take a snapshot of this, but basically what this one says is that if meropenem is ordered, pharmacists do have the ability to dose adjust it. So dose adjust it specifically if it was ordered as 1 gram Q8, the pharmacist can go and adjust it to 500 milligrams Q6 or per renal function. So the 500 milligram Q6, because when this was developed, there was good evidence showing that that dosing was as effective and safe, if not safer, than doing the 1 gram Q8, just in the variability or the difference in the pharmacokinetics and pharmacodynamics. So we do have that policy in effect as well for the pharmacist to be able to adjust the dose. Then in June of 2018, we did develop a outpatient IV or home IV restriction list. So a policy saying that, hey, these are the antibiotics you are able to administer through the outpatient IV antibiotic program. We had never had anything like it before. This was adapted from the one in Saskatoon. I had worked with the antimicrobial stewardship pharmacist out of Saskatoon to develop ours, as they had one already, but we had to tweak ours a little bit because we don't have an infectious disease physician present or always at our fingertips to be able to talk to. So we have to tweak ours a little bit, but basically we have 3 different sections on it. So open means that you can prescribe the antibiotic. It's readily available to you should you need it. And the catch though, or the criteria is that it can only be prescribed for 5 days initially. At the 5-day point, the prescriber or a new provider needs to reassess that infection and see if the antibiotic can be stopped, if it needs to be stopped to oral, or if it truly needs to be continued longer, then it needs to be reordered and we need to receive a new order to pharmacy. The closed section are agents that are available through oral that are as bioavailable as the IV, so they should be given orally as many times as possible instead of IV. The only catch that we have there is that if a patient is truly NPO, they can receive those antibiotics IV for a short period, up to 48 hours, and then reassess from that point on. And then the restricted are the ones that we were seeing significant problems with. We were seeing antibiotics being prescribed for asymptomatic bacteria, and honestly, it was tazocin, it was meropenem, it was aminoglycosides that we were seeing being prescribed for these UTIs where the patients had no symptoms, probably and most likely due to that we had given so many antibiotics already that we caused resistance and we were having to use these big guns per se. So we did put restrictions on them as well, and clindamycin was also deemed as a restricted one because at the time, the microbiologist in Regina did have significant concerns over the resistance rates of clindamycin, specifically in this region, that they were worse than everywhere else in the province. So it was, hey, suggest to not use this antibiotic because it's just not effective. Plus, it might not be a great antibiotic anyway. So this restriction list was created. I will say that it is up to the pharmacist and the pharmacy department to police it, essentially. So every home IV order that is ordered, whether that's in outpatients or long-term care, the long-term care teams, the home care teams, and the emergency department teams know to send the order to pharmacy, and the pharmacist reviews it and assesses if it's appropriate or not, and then ultimately decides yes or no if we're going to dispense that antibiotic to the teams to administer. So there are occasions when this can get extra busy because it is another task on the pharmacy department, but I will show you that it has been quite successful. Then in 2021, our antimicrobial stewardship committee was noticing that when we were tracking all of the antibiotics that were still being ordered, we did see a decrease in the ones we were wanting to see decreases in, but we were still seeing a lot of ceftriaxone and cefazolin going out the door. So we did see that 80 to 90% of our prescriptions coming from not ID prescribers were for skin and soft tissue infections or cellulitis, and then community-acquired pneumonia. So we did develop this order form that the providers use to send their order to us in pharmacy, and it just has the 2 columns there. So that first column on the left is for cellulitis, and it kind of gives some guidelines as to how to treat the cellulitis, starting with the oral being the preferred option, and then the same with the community-acquired pneumonia as well. I will note that there are things now on these restriction lists and the order form that I would update. We just don't have anyone to report it to right now to do an adjustment. So it is on my radar that, for example, the penicillin allergy and community-acquired pneumonia, I don't think I would have moxifloxacin there anymore. I would have a different antibiotic, but these are things that we'll get to, but we are seeing benefit with these order forms. So on to the next one. So in 2023, we had a pharmacy student initially who turned into a pharmacist for us, who did do a review of this outpatient antibiotic therapy restricted formulary a list that we had developed in 2018. And she looked at the data from 18 months prior to 18 months post implementation. And then she also looked at a continued 12 months post the 18 months implementation to see if it continued to be successful. So I'm just going to show you, it is pretty hard to see here, so I'm going to break it down into different sections for you. So this section specifically, so in this top figure, figure 4, it says change in the number of prescriptions after protocol implementation. So in period 1, just to show you the colors, we have dark green, which is pre-implementation. Post-implementation is the green, 18 months post-implementation, and then an additional 12 months after the 18 months is the yellow, okay? So all of these antibiotics here listed are antibiotics that are now on our home IV restriction list as a restriction, that they cannot be used unless there's those criteria in place, okay? So if I go back here, I think I forgot to mention, I did forget to mention, any antibiotic on this list, if it comes from ID, it is okay. If ID is saying you need this antibiotic and you need it for X number of days beyond 5 days, it's good. We're not adjusting that at all. These are the ones that are coming from the general prescribers, nurse practitioners, etc. Those are the ones that we were putting restrictions in place in because we were seeing unnecessary and inappropriate use. So just to clarify, this is not linked to infectious disease prescribing. Okay, so So again, up here, it was the change in the number of prescriptions. So initially, there were 126 prescriptions from general practitioners that were coming out or that were being prescribed for antibiotics that are now on our home IV restriction list. After implementation, when we reviewed it at 18 months, it was down to 64. And after the 12-month period after that, it was down to 32. If we look at the days of therapy dispensed, we initially had 966 days, which was prior to implementation of this restriction list. It dropped down to 328 in the 18-month period post, and down further to 195 days of therapy after that. So we did have, it was a large reduction in antibiotics. I mean, you can see our Tazocin one at the top went from 56 to 15 to 10, large reductions in antibiotics that we would have deemed unnecessarily being prescribed. So it was successful in that sense. I will comment though that I don't know the effect that this had on oral antibiotics. So did the number of oral antibiotics and days of therapy stay the same? Did they decrease as well because prescribers realized that 5 days was enough versus 7 to 10? Or did they actually increase because they weren't able to prescribe the IV antibiotics, so they sent oral? I don't know that. I can only see the IV piece here and the impact that it had. So when I did a review of our 2024 outpatient IV antibiotics, remembering that our goal was to reduce the use of Tazocin, vancomycins, aminoglycosides, and carbapenems that were being prescribed inappropriately by general practitioners, there were none in 2024. So just this past year, we had none of those antibiotic IV therapies coming from general prescribers. We did have treatments for them, but they were done in conjunction or coming from infectious disease. There were no courses that extended beyond the 5 days. We did have occasions where a physician ordered past 5 days, but the pharmacist clarified that they would send 5 days. And then at the 5-day mark, there were a few occasions where they were reordered, but not an excessive amount. And then anything ordered beyond 5 days that was much more long-term was again being done in conjunction with ID. So overall, shorter courses of therapy were observed, which is aligning still with what our poster that was done in 2013 was showing. Closed agents, so those are the ones where we wanted to offer oral as much as possible over IV. They were being held to being prescribed for only 48 hours, no longer. And majority of times the pharmacist immediately jumped them over to an oral antibiotic versus IV. So that was great. There was one clindamycin order, which I think is pretty darn good. It did happen over a weekend when we have limited pharmacy staff. So after the pharmacist was able to intervene, it was changed over to cefazolin. So did have 48 hours of clindamycin use, but one clindamycin IV over a year is pretty great. I do wonder if we still have excessive use of cefazolin, specifically for skin and soft tissue infection, when a cephalexin would be appropriate to be used. I do question that we probably could be going an oral route and are staying with the IV. And then I think the same thing with the ceftriaxone for community-acquired pneumonia. I think there's many instances where dosing an amoxicillin or amoxiclav or a doxycycline over the ceftriaxone could be sufficient, especially in a low curve score for outpatient therapy. But small wins over time for sure. And then of note, prior to this restriction list, we were dispensing or distributing anywhere between 3,500 and 5,500 outpatient IV antibiotics per year. Granted, that is including in the infectious disease approved ones where they sometimes were extended periods of 6 weeks. But in 2024, we actually had 2,167 doses prescribed, which is significantly lower than 3,500 doses and definitely lower than 5,500 doses. So that 2,167 would actually still include the ones that were prescribed by ID as well. So all in all, we had a significant reduction in the amount of doses that we're sending out our hospital pharmacy door for IV outpatient use. So that is our restriction list and the order form. Does anyone have questions about that before I move on? Oh, I don't know if I can see my chat box, Jason. I might just move on and we can answer questions after, unless you can see it.
There are no questions in the chat box as of yet.
Okay. So since the P&T committees are no longer, we've kind of switched gears a little bit. So all previous policies and procedures still remain in effect. So we're still doing the IV to PO pharmacist conversion. We're still following the restriction list. We're still following the other restriction policies, but we have switched over to a greater focus on education just because we aren't able to put any of those black and white policies in place right now. The other thing that we've done for the last couple of years is there's antibiograms. So there is a laminated antibiogram in each inpatient chart. And on it, obviously, is the antibiogram. And then we have little snippets of information. So we do have a reference there to the First Line app and to download it on each person's phone. We do have a little note also about not treating asymptomatic bacteria because that's still an ongoing problem here. So that's one of the things we have. And then the other thing that we're doing, which is occurring through our pharmacy department, is since 2022, all IV antibiotics have a stop date of 3 days. So in BDM, it wants to have an automatic stop date of 7 days, but we have gone and as our technicians do order entry, they change the stop date to 3 days. So that within 48 to 72 hours of initiating therapy, a renewal list prints up to the ward and the healthcare team, including the nurse, the physician, and the pharmacist that is up there, reviews that antibiotic to see if it needs to continue as IV or could it be more appropriate to one, stop it or change to oral. So one thing, or a few things that we're doing there. In terms of education, I have been presenting at the yearly nursing education rounds or the education days. I've been doing it since 2018 and I present on behalf of antimicrobial stewardship and I go out to the various home care, long-term care and acute care sites throughout our former region and I talk to them about antimicrobial stewardship and I'll kind of talk about some of the things I've covered. So that's one thing that is still ongoing. We also, this might not be totally antimicrobial stewardship related, maybe more pharmacy related, but in the past couple of years, we developed a WebEx with the Regina ID pharmacists, so Mel and Kristen, for all of our pharmacists in this former region, Southeast 3 to 5. And it's fantastic. So we have them readily available at our fingertips to ask them questions about anything complicating, anything unique, anything we have questions about. And because it's a group chat, then we have ability to go back and find answers from previous, and we all learn from each other. And it's gotten to the point now that when we're on the wards with the physicians, they'll often say like, well, don't you have access to those pharmacists in Regina that can help you? So we use them a lot and we thank them a lot for all that they have supported us with. The other thing that we have done is some physician education. So part of the education happens briefly at orientation. So when a new physician comes here, which we do have a large physician turnover in this area. So at orientation, our pharmacy manager kind of talks about how pharmacists will be involved with antimicrobial ordering and some of the different supports and policies that are in place there. We have tried a few education sessions. So since 2018, we've had 3 where we've had an evening presentation either by the Saskatoon or the Regina ID teams, including the pharmacists who have either come out and or been virtual, and they've done a session to our prescribers. And then the last one we just did was in June, actually, and I had recorded it as well. So it is available on the SHA antimicrobial stewardship page as well, if anyone wants to get a little session on appropriate antimicrobial prescribing. And then the last way we do some education is informally at rounds. And this is definitely on the pharmacist teams here who are hip to hip, side by side with that physician, Monday to Friday on the medical wards and medical ICU and surgical wards. And they are talking to the physicians and continually and consistently reminding them about appropriate antibiotic guidelines and durations, and asking them if the antibiotic can be stopped or reduced and all that kind of stuff. So that's some of our education pieces. When I present to nursing teams at long-term care, acute care, and home care, these are some of the toolkits that I've used to talk to them. So one of my big ones is the AMMI Canada Symptom Free P Let It Be campaign. And I know this is old now, but it's still so applicable because we see so many antibiotics being prescribed for bacteria that's just hanging out in the urine, not causing any problems, and we should just leave it that way. So I do mention this toolkit a lot to the nursing teams, and I use a lot of the references to talk to them about just stop smelling the urine, stop looking at the urine, just let it be. The memo on the left there is a memo that we created through our local antimicrobial stewardship committee, just as a reminder to our local teams that we put on the nursing desks. We've put in physician break rooms, we've put in physician work areas, all the different areas that healthcare team members might be, on the appropriate use of antibiotics for UTIs and when they're actually required versus not. And then choosing, there's another example there on the right from Choosing Wisely, of another kind of campaign type of thing of when we should actually use antibiotics in asymptomatic bacteria. The other thing I always like to tell the nursing teams about is this one example, which isn't unfortunately a unique example, but on the left there, I talked to them about, like, look at this patient who was on, and this is a patient from our area. Look at this patient who over 282 days had antibiotics, 142 out of the 282 days for UTIs. And it's just like big eyes, deer in the headlights, what on earth? Because I remind them that on admission or in their care facilities, that's kind of just a snapshot of what's been going on, and that we often don't see the collection of antibiotic use between home IV, regional, tertiary hospitals, all the different hospitals they might be at, combined with their community prescribing. So this was just one example that I show them. And I also like to talk about a lot about the spectrum of antibiotics, because when I'm on the ward, I often hear, oh, you need to be on this antibiotic because it's the strongest one, or you need to be on this IV antibiotic because it's the most potent. So I try and remind the nursing teams that antibiotics aren't about potency, that they're more about the spectrum of the bacteria that they cover for each antibiotic. Data collection. I did do some data collection, and I still am doing some data collection. It first started with defined daily dose data, and I did collect this for a few years, but I have since stopped in 2021. And the reason for it is that it was good to allow to see trends in average of daily doses of antibiotics being prescribed, and I could track the usage over months and years. So for example, I could see that during cough and cold season in the fall, we had an uptick of ceftriaxone and azithromycin usage, probably linked to more community-acquired pneumonia cases. Or another example would be when I first took over chairing this committee, there was an excessive use of vancomycin, and we worked really hard at decreasing our rates of vancomycin here in our hospital. So I could see when I was tracking that data that our vancomycin usage was slowly decreasing. But quite honestly, this was a cumbersome process and it took a lot of time to collect this data. So I did stop. And the other reason I stopped is that we weren't doing anything with the data. So it was cool to see the numbers, but we weren't actually using it for audit and feedback or for any purpose of that. And I just didn't see the rationale of continuing on. And the other thing that DDD data doesn't do is it doesn't correlate to the infection that we're using the antibiotic for, or necessarily assess the appropriateness based on the individual at hand. So it's not assessing for renal function or duration of therapy, that type of thing. So had tried it, no longer doing it. The other thing I just did within the last couple of months is I did the NAPS survey. So if you haven't heard of NAPS, it's the National Antibiotic Prescribing Survey. It's a point prevalence survey, and it's fantastic. It allows for benchmarking to compare to other sites within Canada who have also completed the NAPS survey, and it allows you to assess the number of antibiotics and their appropriateness. So there is a good methodology in place for capturing the data, and guys, it's really easy to set up. I was able to connect with the person who sets it up, get an account set up for myself. And our hospital that has 100 beds, I was able to collect all the data and assess it in one day myself. And then I was able to input the data over part of a next day. So I did use Kristen to help me assess appropriateness on some occasions on things I was a little unclear of, but it does have really nice rubrics and charts that you can access to help guide you if an antibiotic is appropriate when you're inputting your data. So this is just an example of some benchmarking that it can do. So the Yorkton Hospital's data is there on the left, and the benchmarking to the national other sites is on the right. So you can see that we're compliant with guidelines similarly with the national, but that non-compliance we are definitely lacking in. We were high in that category. So some ways that you can be deemed non-compliant is if you use too high of a dose of an antibiotic, if you use too long of a duration of antibiotic, or if the antibiotic was just completely not appropriate. So this is just one example. There are many different charts and many different data assessment tools that you can use to find what works for your site, but this is just one example. Okay, so I will say that although we have an active antimicrobial stewardship committee here, this program would not go well if we didn't have the support from our pharmacy departments. So the teams in our regional hospitals, as well as our smaller community hospitals in our rural sites, all contribute to our antimicrobial stewardship efforts. We have technicians that perform order entry at all sites, and they do a really fantastic job, and they're really diligent in ensuring that first doses and last doses of antibiotics appear on the MAR. They actually type in first dose, June 26th, last dose, June 29th. And they adjust the stop dates of all IV antibiotics to 3 days, and they ensure that azithromycin 500 milligrams is always stopped after 3 days, that it's not continued. Also, the pharmacists are rounding with the physicians daily, and we're always reminding them about the current antibiotic durations and what the guidelines state for the specific infection. So as much as we are a committee of multidisciplinary people, we do rely on our pharmacists and our pharmacy teams a lot to help us out to carry that information forward. I'll just show you an example within our pharmacy department. We use shadow documentation to help handover between the pharmacists. So here on the left here is an example, is a copy of our shadow documentation. And then on the right here is just how we input antibiotics that are being ordered for each patient. So for every patient that is admitted to our hospital, they get a shadow documentation sheet. So on every patient that is admitted to hospital, we write if they're on an antibiotic and when it was started and how we're assessing if it needs to be stopped, that type of thing. So we are tracking antibiotics through our pharmacist teams. And then just to talk about where we're headed next. There are some SHA committees that are starting, and they're starting to focus on antimicrobial stewardship and infectious disease prescribing and management. So we're kind of just keeping an eye on these groups and seeing what type of guidance might come out of them. But because sometimes things are slow moving and we want to keep things moving forward here as well, we are looking at a few other things that we might try over the next several months. So Timeout Tools is a formal document that Kat Neal out of Lloydminster is utilizing with her antimicrobial stewardship efforts and her pharmacy team. So something that we might look at here in Yorkton. An area, as much as we are tracking antibiotics and talking to the physicians, using a formal tool where we're actually ticking off and putting into the chart might be something to look into. So that's an example picture of a snapshot of a timeout tool that you can use. And then we might try some audit and feedback to physicians as well. And I will work with Jason and Kristen and Mel to work on some of that, of how we might be able to chat with our physicians about their prescribing and give them some feedback on it. We are setting up a plan for the World Antimicrobial Resistance Awareness Week in November, and then we'll continue that education. So to end, this is what makes me happy. So I don't know if every pharmacist and every pharmacy staff member in my facility is as passionate about antibiotics as I am, but I am very, very thankful that they go along with my pushiness to get patients off antibiotics and keep the antibiotic prescribing as appropriate as we can. And these are the things that keep me happy that I hear. So on the other day on the ward, a nurse said, the urine is cloudy and smelly. And the physician said, oh, maybe we should send for a CNS. And the pharmacist said, wait, why are you smelling it? That's not a sign of a UTI. Have we tried giving the patient fluid? And the physician said, okay, we will wait it out and monitor the patient. Or in the pharmacy department, when a pharmacist says, I can never get this prescriber to skip down to antibiotics, but they just transitioned to oral and decrease the duration. A little win. Or via feedback. So I recently just had a former pharmacy student who's now a graduated pharmacist who sent me a message that said, hey, I spoke to a patient who was coughing for a few days. The chest x-ray was clear and they were prescribed an antibiotic because it could be pneumonia. I talked to them about the pros and cons, mainly the cons, and they agreed to log the antibiotic and wait and monitor. They called me a few days later and said they were feeling much better and thanked me for giving them the info and that they never filled the antibiotic. So when we talk about antibiotics, and we continue to talk about antibiotics, our good work does go a long way. And these are the things that I am thankful for my pharmacy team for pushing antimicrobial stewardship. So thank you, pharmacists and pharmacy technicians who are listening. So I think a little can go a long way. We're a small group, but I think we're a mighty group. And there's little things that you can do that make a big difference. So the first one, download the First Line app and use it. It's developed by experts on infectious disease here in Saskatchewan, and it's all developed to coincide with our resistance patterns, and it's fantastic. It's easy to use, it's simple to use, and I think if we follow it, we can have good prescribing. We can make sure good prescribing habits happen. I think it's important to reassess your patients daily, and the old saying of you have to use your antibiotics until the end, until there's no more, isn't really a thing anymore. So keep reassessing those patients daily and connect with the experts. Jason and Mel and Kristen and all the other ID and antimicrobial stewardship people within Saskatchewan are so fantastic in helping, and they are more than willing to walk you along and guide you down whatever path you want to go through for your antimicrobial stewardship. So definitely connect with them, and also connect with sites like us, where we've been doing antimicrobial stewardship for a while, and we might be able to give you a few tricks too, or pass you off to Jason and Mel and Kristen, who can help you as well. I know Kat Neal and Lloyd also does a lot of antimicrobial stewardship, and she would be happy to help as well. So feel free to reach out at any point. And I think that is the end of my presentation.
That was fantastic. Thank you, Kelsey, very much. A couple of quick questions. I'll jump to them right away before people have to run. Amanda, who also just said awesome info, thanks, asked if you're able to share with Southeast 6. I think she posted that question when you were talking about the education stuff, but Amanda, feel free to clarify if you had other things in mind. Presenting to nursing groups, there you are. Are you able to share that with Southeast 6?